pledges just demonstrate your commitment to teaching and your commitment to your faculty appointments. Thank you so much for being here. And I don't think that you will find this at all a waste of your time. It's been great so far. We've had our first two sessions. This is our third. So I can't tell you how happy I am to introduce my friend and colleague, Dr. John Mann, as today's Education Grand Round speaker. John and I go back, I think, 10 years now of knowing each other and working together on various projects. And I have learned a ton from him, and I will continue to learn a ton from him. And I feel you all will learn a bunch as well. So Dr. Mann is currently at The Ohio State University, where he is Professor of Pediatrics, Associate Director for Education in the Center for Faculty Achievement, Mentoring, and Engagement, Senior Editor for their online faculty development program, Medical Director for Nationwide Children's Hospital's Metabolic Bone Clinic, Director for the Pediatric Nephrology Fellowship, and Director of the Pediatric Residency. And that's just amongst two other things. Got a lot going on. Dr. Mann completed his undergraduate studies at LaSalle College, his medical degree at Hahnemann Medical College, his pediatric residency, chief residency, and pediatric nephrology fellowship at the University of Minnesota Medical School. Over the years, Dr. Mann has received numerous honors and awards, and just a few of my favorites are repeated Outstanding Teacher of the Year Award, the ACGME Parker J. Palmer Courage to Teach Award, the Arthur Gold Humanism Society membership, and Nationwide Children's Hospital Career Achievement Award. So these aren't little awards, these are big awards. So, and you will see that he is well deserving of them all. So well beyond my years of knowing him, he has been an excellent teacher and he's been a consummate professional. So here to talk to you today about how to better teach and assess professionalism, Dr. John Mann.
Wow. Thank you, Sherry, and thanks for the highlights. Actually, as Sherry knows, we have 8 kids, and I consider that my biggest accomplishment. And I've learned a lot, and as I say, it's painfully acquired wisdom. I'm not sure if I learned more from my residents or from my kids, but they both helped shape me, that's for sure. And I've been a pediatric program director since 1990, and when Sherry asked to talk on professionalism, I said, well, are you kidding? I live this stuff. We deal with this all the time. So what I'm going to talk about really is embedded in what we've dealt with over the years and the challenges with our students, our trainees, and our faculty as well. And the idea of teaching and assessing professionalism is really important because in our view, assessment drives learning, and if there's not some assessment, you're probably not going to really get the kind of learning that you desire. So we are going to focus on some ideas about assessment, some things in the literature about assessment, and then a little bit about what we're doing with assessment. And I can tell you that my understanding of professionalism and ability to teach about it is a work in progress. So hopefully you'll kind of help me progress as well, because we still have a lot to work on and learn. So I titled this New Paradigms and Tools because there are some sort of new ways of thinking about professionalism that I think are really useful as we think about how we might organize our educational efforts. And there are some tools out there now that have been written about and validated. And as I'll show you, there's actually more tools than you'll have time to do. So some of our challenge is picking a couple assessment tools or methods and trying to get some experience and use out of them. So at the end of the talk, what I hope you'll really remember are these 3 dominant models or paradigms of professionalism, because I think it's a key construct to frame our thinking. And then 3 methods for teaching professionalism. We'll cover a variety of methods, but I hope you'll be able to come away with at least 3 that make sense to you. 3 methods for assessment, and then at the end of the talk, I'm going to challenge you to commit to action And what I will ask you to do is commit to either read more about one of these topics, discuss it with a colleague, and or try implementing one of the things we'll talk about today. And you should have a handout, and in the back page is your commitment to action. You get to keep the handout. My email address is at the bottom of that if you have any questions, if you'd like a copy of the slides. I know Sherry's going to post the talk and the video for you on your own internal website, but I'm happy to send slides to you and use them as you may. So I'd like to start off with a couple quotes that really help put what we're talking about in context. Kathy DeAngelis, who was a noted editor of JAMA for many years, back in the late 90s, said, "There seems to be no agreement on what the term, i.e. professionalism, means." And I'm here to tell you today, in 2017, there is no agreement on what the term professionalism means, which means I have lots to talk about. David Stern, the guru of reflection, was quoted as saying, "Role modeling must be combined with reflection on the action to truly teach professionalism." And if there's one dominant development in professionalism over the last 10 years has been this infusion of reflection, reflection being an important part of development of students and residents. I can tell you from my perspective, reflection never made sense, for me and most of my colleagues, and we went into medicine to do, right? If we wanted to do reflection, we would have gone into art history or philosophy or theology, right? I mean, we're doers. So I think it is a little bit of a frame shift to think about, okay, we actually should be like thinking about what we're doing and reflecting on it, really. But I do see the students of today that are charged with doing reflections benefiting by it. And I'm struggling with thinking how we can incorporate that into graduate medical education, because I think these students are going to come along now actually having done it and seeing the value. And as you'll see, that is a really interesting teaching method in professionalism. Mueller said, "Because of the nature of professionalism, no single tool for assessing it among medical learners and practicing physicians exists." And what I'm going to talk to you about is really that there are multiple methods. And I'd like to turn that around and say a strength of teaching professionalism is we have multiple ways to do it, and they complement each other. And a strength of assessment right now is that there are lots of different methods. So we don't have to feel tied to one method that maybe doesn't make sense or doesn't work in our microenvironment. Tallis said, "And indeed, if the values and commitment that have made modern medicine possible, creating both the powerfully effective technologies and forging the therapeutic partnership with patients are lost, then medicine will very quickly run into serious difficulties." And this really is why this professionalism topic is so important and why this needs to be an explicit conversation. And as we'll talk about, when the American Board of Internal Medicine developed Project Professionalism in the late 90s and promulgated what they proposed should be the common values of professionals in medicine, their charge was to make explicit what everyone assumed was known, and to say, no, we need to actually have explicit values that we talk about, that we make sure our learners and our future professionals embrace. So it really is part of avoiding those serious difficulties. And then lastly, no talk on professionalism could go without a quote from William Osler, right? And as Osler said, you're in this profession as a calling, not as a business, as a calling which extracts from you at every turn self-sacrifice, devotion, love, and tenderness to your fellow man. We must work in the missionary spirit with a breath of charity that raises you far above the petty jealousies of life. And Osler thought he had it difficult, right, back in the late 1800s, when they were worried about physicians that were more interested in making money than helping patients, that were taking advantage of quick strike-rich schemes, that were not necessarily following the standard of care. Sound familiar? But what our learners are in is a much more complex and challenging world. Economics of medicine, the technologies, the treatments, the costs, the social demands of those of us in the profession. Think of the librarian of 20 years ago and how information management is different in 20 years. It is so much more complicated, the world that our students and residents and fellows are stepping into. And yet at the same time, professionalism has such a tradition, right? Remember Hippocrates, that guy? That was 400 BC, over 2,400 years ago. They were talking about, having an oath so the physicians will remember to put the patient in front of their self-interest. Sound familiar? So we really have to embrace the fact that there is no one way to develop professionalism in our learners, and to recognize that there are different ways and different methods, and we need to think about how we choose what we choose, and recognize that our learners are going to have different insights as well into what they are evolving to become in terms of their professional identity. And then lastly, I think there's room for improvement, and I'm going to show you some methods that have been experienced and developed, and some assessment methodologies, but there's a lot of work to still be done. So if nothing else, I'd love for you to have this image in your mind when you think about professionalism. So Irby and Hamstra last year really did a terrific job of really laying out the professionalism paradigms, the three dominant models. And we're going to talk about these. There's the model of the virtues or values, the behavior model for professionalism, and the professional identity formation model. And these three are connected. They inform each other. And I would argue any one of them by itself is insufficient in terms of really developing the professionalism that we would like to develop in our learners. So we talk about the virtue model, and every year we have our new pediatric residents, I ask them, how many of you have had a lecture in medical school on professionalism? Everyone raises their hand. And then I say, how many of you would like another lecture on professionalism? And everyone's hand goes down. Okay? And what's happened over the last 20 years is these conversations about the professional values, professionalism, core values, virtues, has become explicit. And I would argue that's sufficient, but not, I would argue that's necessary, but not sufficient in terms of our professionalism education. It's an important foundational step. We need to make sure it's being done. When we talk about virtues, which are really actions that are tailored to accomplish good, we recognize that that's part of our professionalism, that these shared virtues or values. We recognize that that's part of being a moral character, but we also have to recognize that these are not things that go like that. You have them or you don't, or you get a lecture and now you got it, right? These values are things that are developed in individuals. One would argue a lot of those have been developed in the playground and the sandbox, but we recognize that we still have to have these explicit conversations and discussions with our learners. Ultimately, these virtues allow our professionals to really reason through difficult situations and equip them for moral reasoning, and it really informs a lot of the humanistic part of medicine. And this is an important part of that paradigm. One would argue 20 years ago, as the professionalism values became a popular topic, this was really the focus of professionalism education. The behavioral model, though, has really become the dominant model of professionalism education and has some real obvious advantages. First, by focusing on professionalism behaviors, you're focusing on what can be objective and what happens. The way you perform, behave, becomes the subject of discussion and ultimately the measuring stick. So we don't have to worry about what you're thinking or what your motivation is. It's what you did. How did you perform? How did you behave? What were your actions? And in this predominant sort of paradigm now, there's more focus on how you perform. And we have things like milestones in the graduate medical education world, ACGME milestones, that actually depict certain behaviors in specific professionalism domains and competencies that we can think about in terms of professionalism. I know in pediatrics now, we have more pediatric milestones on professionalism we have to report on than on patient care, probably for a reason. But what we're called upon is to really look at our residents now in pediatrics in terms of important professionalism behaviors like compassion, respect, commitment to excellence. I mean, things that are really important parts of our professional identity. So the behavior model has a lot going for it, as we'll talk about, really has the most assessment methods linked to that. The third sort of paradigm that I think you will see become more important in the future is this concept of professional identity formation. And in a sense, professional identity has formed in all of us as we came up through the ranks and all of our learners. Our learners will join our profession. They will have a mental model. They will have a construct of what they're about as a physician or as a nurse or as a respiratory therapist, PA. When they join the profession is the beginning of developing their professional identity. And as you know, it doesn't stop when you graduate from school, but this really is a developmental construct that talks about the individual developing their sense of who they are, what it's like to be in that profession, and how one should behave and ultimately does behave. So it has a nice developmental kind of model to it or underpinning. It really is formed by social contacts. So this is really the role modeling that so much drives professionalism, understanding, and ultimately actions, for the good and for the bad. This is where the learners, typically with more experienced faculty or senior residents, begin to see that's what a doctor is, that's what a doctor does, and the same in all the health sciences professions. Those role models are a key part of professional identity formation. And again, that's been going on forever. What's changed about this concept of professional identity formation is really being more explicit about the impact of what our learners are learning and trying to move from, in a sense, a tacit or a hidden curriculum to one that is explicit and discussed and reflected upon, and therefore, hopefully, more powerfully internalized and acted upon. And this professional identity really brings in this social good, this social compact, what's expected of us by society, not just in our profession. So we're going to talk about those three in a little bit more detail, but first I'm going to have you answer a question. Given that all three of these models have a long history and real value, which one speaks most powerfully to you as a means to frame professionalism, development, and assessment of your learners? So I'd like you to think about that for a few seconds. One of them should speak to you more. And then I'd like you to turn to the person next to you, and I'm going to give you 2.5 minutes to make your case. The two of you can talk about it. Okay? Go. And it can be groups of 3 if that works better. Okay, all right. I'd like to bring you around a little bit now. I think what I detected is you're having entirely too much fun talking about this topic. But what I'd like to do is get a sense of the room and wonder how many of you have the sort of virtue paradigm speak most powerfully to you as a means to think about framing. Big group. How about the behavior model? Okay, and then how about professional identity formation? Yeah, interesting. Yeah, typically behavior model dominates, but I'm seeing more people sort of seeing that maybe this professional identity formation is something that speaks to them as a means to sort of organize their thinking about the educational process. And as we'll talk about, I think we pick and choose from all three, and we recognize that they complement each other, okay? So it's not that you have one and you completely ignore the others. But as we'll talk about, if you're really in an educational leadership position developing curricula, there's power to thinking about taking stuff from multiple paradigms. And in assessment, as we'll talk about, as an educational leader myself, we can't do more than 3 assessments. I only have so much bandwidth, but we try to do assessments in a couple different areas, okay? And then I think there's also a piece about this to really just recognize that there are going to be parts of professionalism development of your students and trainees that individual faculty do, and maybe they can get good at one area and help you as an educational leader in one area. So thinking about it that way. So just to reinforce some of the assumptions behind these 3 models, because again, if there's nothing else about this presentation, if you leave with these 3 models in your mind and sort of see the potential, we will have accomplished something. So when we talk about the virtue-based, the assumptions are that if you internalize the right values, if you really get them in your core, that you're going to develop the right kind of ethics and habits. So the strengths are the focus on internal values and the focus on making it explicit, with the idea that you'll then be able to apply it not just in moral reasoning exercises, but in real life. The behavior-based, those assumptions are really clear, and that's why most of the time when I give presentations like that, this one makes the most sense, because it's behavior, it can be made clear, the expectations can be articulated, and the assessment, we're just going on how you behaved. It's a great tool for feedback. And as we'll talk about, the idea of professionalism lapses, which comes from the professionalism behavior model, really can be an effective tool to help learners get better. And then professional identity, which again, I would argue goes on even if we're not thinking about it. There's some real interesting stuff coming up showing that spending more time on focusing on your identity as an early learner, and even as you progress through the learning arc, can have some real value to making these professionalism sort of thoughts and feelings and actions stronger inside our learners. So I could kind of summarize it by saying when we talk about professional development, the virtue area really talks about helping the learner internalize and gain these virtues and really to use moral reasoning. The behavioral model really focuses on clarifying expectations, teaching about actions, providing feedback in terms of what is observed in that developing professional. And then the professional identity, really the idea of focusing on positive role models and in a sense utilizing negative role models as a good educational tool. Okay. So if I could sort of summarize the principles for professionalism education, first of all, I'd say it's needed. We can't assume it's going to happen well without it being explicit. And we need to focus not just on knowledge or virtues and concepts, but also on behaviors and skills. And we can't assume people are going to get it without us having some intentional teaching. As we'll talk about, I think it's foolish to think one method's going to work, so we really have to embrace the fact that there is no one best method, and that's okay. But it's more likely to take if our learners get teaching and learning about professionalism in multiple dimensions. And then lastly, we can't assume anything. We can't assume that people got it until we actually have conversations and observe behavior. And ultimately, assessment drives learning. So recognizing that my professionalism is actually being looked at, measured, will be discussed, helps learners focus and learn better. It works in every other area of medical education and needs to be considered here. So I told you we get the methods. So here's 6 methods of professionalism education that we've had experience in working with. So first of all, the lecture. You can't deny the lecture has power. Everyone's had lectures on professionalism. What we tend to do is have a little 10-minute mini lecture inside a case-based discussion. So we make sure that our learners have heard the virtues, and I'll show you an example in a moment. So we make sure that it's covered, but 60 minutes of it is deadly. So we kind of build that in. What we've had the most success on is case-based discussions. Students, residents love a case. The key here is that the cases are authentic. So when I do a professionalism workshop with OB/GYN residents at Ohio State, I get cases from the chief residents or program director that have happened, that are real, that they've been struggling with. And they become wonderful teaching tools and really help show that professionalism is a real thing. You know, it's how we have to, how we can confront these challenging episodes in our professional career. Case-based discussion can certainly utilize video clips. It can utilize stage performances. A lot of times just the description of a case, and I'll show you a couple, is a wonderful taking off point for professionalism learning. Sentinel events have a lot of power. Sentinel events, particularly if you de-identify them, can be wonderful teaching tools. So we just recently had a really passionate advocate, pediatric resident involved in Twitter, who got into a Twitter war with anti-vaxxers and basically said some very unprofessional things. And of course, these anti-vaxxers in the state of Ohio are smart people. They went right to the hospital and lodged a formal complaint about this third-year resident being unprofessional, and it was. We had to deal with that, and he learned a lot from it. But I took that and de-identified it and made it a teaching case for the residents. What better way to teach social media and Twitter than to actually have an example of a good person that, you know, kind of made a mistake and lapsed to become a sentinel event. Just like you might have a sentinel event in the ICU or with medication errors, we can have professionalism sentinel events, and they're wonderful teaching tools, unfortunately. We've had really good success with forums or panels. So when we talk about some of the struggles around communication, we get 3 of our faculty that are really good at communicating and staying professional in difficult settings where communication is strained, and have them talk about how they handle problems and give them a case or 2 to play off of. And the learners hear this discussion, right, and realize there isn't always one answer, and can in some ways pick and choose from the solutions that they hear that sound like that they would really be most in their power to pull off. So panel discussions around professionalism things. So we'll utilize video clips, for example, that really draw the audience in, and then have a panel discuss reactions to that. So that's a really effective teaching method. And then what we've seen more of the last 5-7 years is reflection with discussion and reflection with writing. We have medical students now that are required during their first 15 months in their clinical exposure to comment on professionalism challenges or things that they saw that they wondered about the professionalism, and to actually reflect on those. And those reflections are read and graded by their portfolio coach. And using a technique that I'll show you later, you can actually assess the depth of reflection. So in other words, they don't just write 250 words to say something, but they actually have to probe what is going on and explore it. And what we see is these students develop better reflection over 15 months, 6 cases over 15 months. It's incredible. And again, I think really helps them confront what it's like being a professional in these challenging situations. And then, certainly reflection with discussion having a case or having an issue that they require to write about, and then share that in a small group or large group is another really effective tool. So here's 6 methods for teaching professionalism. So on your handout, there's a matching test. So what I'd like you to do is match up each of these 6 methods with which of the 3 paradigms would that method particularly address. Does a method like lecture address more the virtue-based model, the behavioral-based model, or the professional identity formation? So for each of those 6 methods up on the screen, they may address multiple paradigms, but I'd like you to identify which is the major paradigm that would link to. And when you're done, you can put your pen down, and I'll know you've completed your matching assignment. So, okay, we will not be collecting your assignments, so you get to keep your hand up. But here's how I would do that matching test. I would say, when I'm talking about virtues, a particularly powerful thing is lecture. I mean, you present the concepts, some discussion, but you really got to get the word out. When we want to focus on behaviors, case-based discussion, dissecting how people would behave, how you might remain professional, what would be some best methods is useful. Sentinel events really address behaviors. And then forums and panels, getting different individual faculty or senior trainees to talk about how they would approach problems really helps focus on behaviors. And then for identity formation, although a number of these all help inform the professional identity, the 2 reflective methods really speak to identity formation. Okay, so I just want to highlight a couple other points about the methods. One is in the virtues and values. One of the things that we find is really powerful is to actually have that group confront what is their own expressed values. So what I'm showing you here on the left is the American Orthopedic Association values for an orthopedic surgeon. This is what the orthopedic surgeons say they aspire to be. So when I do a workshop with orthopedic residents, they've never seen this, right? It's on their website, but no one's ever seen it, right? But we talk about, well, what's prudence mean? And what's caring and compassion? Where are there examples where you've seen some of your fellow colleagues and faculty do a really good job in these areas? Do a not so good job in these areas. You know, try to kind of say, these are your values. This, for example, is the Project Professionalism 6 core values that the American Board of Internal Medicine published around 2000. They call them the tenets of the profession. So again, lots to talk about in terms of, what's commitment to excellence mean? What's that, what's a physician who's committed to excellence aspire to accomplish when you're out in practice 20 years from now? How are you going to stay committed to excellence? What have you seen? So these are kind of the virtues and values, and there really is usefulness to having lectures and presentations. I've yet to come up with a good, engaging online module that anyone wants to do on these virtues and values, but it's important. When we talk about the behavioral methods, we really have been informed with this concept of professionalism lapses, with the idea that good health professionals that find themselves in difficult situations when they're tired and hungry and frustrated at home and have had their 5th admission break down and snap at the nurse and say something really nasty and get in trouble. Well, we assume that resident didn't want to get in trouble. You know, they didn't want to be called into the principal's office, right? They didn't want to, be seen as a bad person, but they broke down. And we talk about these problems with professional performance and behaviors and really approach it from a standpoint of sentinel events and medication errors. You know, the Swiss cheese all lines up and the medication error occurs, and we feel that the same thing can inform us in thinking about professionalism. So Catherine Lucy, one of my mentors in developing our education around professionalism at Ohio State, really charged us to develop a group of educators to focus on developing professionalism in our learners. And you know, her really valuable commentary a few years back was the problem with professionalism, and really focused on the fact that because someone does something that's not professional, we can label them bad and get rid of them, and soon we won't have anyone left working in our facilities, right? We all break down. I share the times I've broken down when I'm talking with our trainees. But what can we do to build more resilient individuals that are not as likely to break down when they're confronted with a difficult situation? So the idea is to really get more into prevention and education and away from bad person, to really get into root cause analysis and to think about, you know, why might a professionalism lapse occur in this situation, and focus on, was it a deficiency in knowledge, in judgment, were these professionalism skills that were insufficient, or sometimes the system is so bad and sets individuals up that it's hard to remain professional. So in this new sort of professionalism lapse paradigm, professionalism error paradigm, the focus is not on these character traits that you have or don't have, but how can you be resilient and remain professional even in stressful situations? Lapses are common and they happen to good people. So how can you develop knowledge and judgment and skills, and how can we improve systems so that you're less likely to have a lapse in professionalism? And then we evaluate by observing in low stress and high stress. So as we'll talk about, when we do our 360 multi-source evaluation of professionalism, we do it in our PZR. What better place for residents to break down, where it's busy, there's like a never-ending supply of patients, everyone's a new case to them. This is where they get into professionalism problems of interacting with other members of the team. So that's where we monitor professionalism. We go with the idea that, you know, we're observing and we're going to help and educate, not fire. And we recognize that a lot of professionalism challenges are really one where there's competing priorities, right? Competing values. So this is one of the classic examples we use with the medical students. A student's instructed by his attending to not tell Mrs. Smith her diagnosis of breast cancer, but to wait until he comes by to talk to her. And so, of course, the student goes in at 7 a.m. and Mrs. Smith says, the nurse told me the report came in last night on my breast cancer. What is it? Well, you know, a lot of students will say, I haven't read it, or you know, they'll dodge it, and you know, you get into, you know, this sort of a conflict between, do I omit or actually lie so that I can avoid making my attending upset, or do I have Mrs. Smith be upset because I'm not going to talk to her about what she needs to be talked to right now, and she's going to have to wait multiple hours? And how do you navigate those conflicts of professional values, of being caring and compassionate and being respectful and honoring your attending's wishes? So these are real problems. And as we have cases that are authentic, that our learners, whether it's students or residents, fellows, have actually confronted and seen, they become really good examples of, you know, even good people can sometimes make the wrong choice and learn from it and hopefully get better. So here's a case that worked recently with one of our surgical subspecialties. It's Friday morning, you're struggling to get through rounds and get to clinic. You're paged by case management and berated because one of your patients has been in the hospital now for over 2 days. It does not have a certification note. He demands that you enter that note now so that the hospital will be able to get paid for this admission. So what do? You got patients waiting, you're getting screamed at for not having something. By the way, this isn't even your patient. You just picked the patient up this morning, and you're getting grief about it. So when we have these conversations, it's amazing how the senior, the PGY 5 and 6 residents are like, yeah, been there, done that, and yeah, here's how I handle it. And the PGY 1s are like lapping it up because, you know, they haven't been in a situation yet. They'd like to have some thought of how they might respond when this happens. So, so again, having cases that really are authentic to the learners in their environment is a key to this kind of professionalism education, and really can focus on the fact that, you know, yeah, good people can make mistakes. It's how you learn from it and do better in the future. And then how can we set up systems so that these kind of professionalism challenges aren't hitting you all the time? And then lastly, in educational methods, there's that professional identity formation construct. And recognizing that professional identity is going to be formed anyway, role models are going to have their effect anyway. But this in particular really works on that internal concept of being a physician and what's expected of you, and ultimately what you think about and feel like and act as a physician. So this professional identity formation by necessity talks a lot more about the inner life, so that's where reflection, but also discussion is an important part. And so in professional identity formation, we really can help our learners with some of those questions about who do I want to become, what kind of doctor do I want to be, and recognizing the impact that role models have, and both to the positive and for negative role models, how that can be a positive impact on developing your concept of what you're going to be, the values that are assimilated and ultimately expressed in actions and behaviors. So when we talk about assessment strategies, we can think similarly that there are certain assessments that work best for in the virtues paradigm. Things like written exams can really address whether you know the virtues. Reflection, in particular self-assessment, can have you grapple with those virtues, and we can observe whether you live those virtues. Under behavioral side, again, written exams where there are cases and choices can help sort of have people think about what behaviors would they choose in sort of the simple test environment. But reflective exercises can be important, as well as in particular things like observation, multi-source assessments, critical incidents, discussions. And then I'll show you a professionalism CEX called the Mini X that can be used in this sort of behavioral focused assessment strategy. And then in the professional identities, we can talk about the value of reflective, in particular self-assessment exercises can do to help people think about their professional identity. And then, again, the power of multi-source assessments and reasoning exercises. So when we talk about these assessments, the challenges are there's lots of assessments, and there's no one best assessment. But again, that can be a positive in the sense that you pick what might work for your faculty, what might work for your learners, what fits your own environment. I think the key, in my view, is that if you don't have some assessments, you're really not going to know how well your learners have learned. So it's really incumbent upon us to incorporate some assessments, even if they're not always perfect and it's not obvious. So I'd like you to think for a second, which professionalism assessment models do you currently use with your learners? Okay, and if many of you are struggling, that's not a surprise, because I think by and by the assessment part of professionalism is the harder part. It's hard enough on the teaching part, but it's an area that really has been under-addressed by a lot of educational programs. And I'm going to show you some data from the literature about some of the different methods that are out there and available, and really, again, challenge ourselves to think about how we're doing this professionalism assessment. So here's a table adapted from Wilkinson's academic medicine paper a few years back that outlines a number of different methods that have been published in the literature that assess professionalism, ranging from observed clinical encounters to multi-source feedback to simulated cases to professionalism being incorporated into the global end of rotation evaluation, to patient feedback, to self-assessment methods, to reflections that are actually read and graded, to knowledge and moral reasoning exams, and professionalism lapses, critical incident reports. So there are methods out there, and I'm going to have time to cover a couple of them and tell you a little bit about what we've embraced in terms of our own assessment methods. So the professionalism mini evaluation exercise, the PMEX, is one that's been validated in the literature. This is a Canadian construct. It's a mini, it's 21 items, so I don't know what their maxi would be like. And 21 items is a lot for faculty to have to think about. Completing the form takes less than 5 minutes, so it's really what you observe during a clinical encounter. They do state that they had to spend some time training their raters to get any kind of consistent evaluations, so that's a challenge. But it is a validated tool, and by having faculty spend a little bit of time thinking about what they're supposed to be looking about in professionalism, and then having them be in the clinical encounter with the student or resident and then fill out the form, you get some real interesting observations and data. The standard direct observation assessment tool was developed in emergency medicine. It's actually an assessment tool of a clinical encounter, but embedded in there are several professionalism questions. So while the faculty love to observe clinical care, what you're doing is asking them to make a couple observations on professionalism in there. It turns out that it really had a lot of ease of use. They had high inter-rater agreement with minimal training. It was found by faculty to be very practical, and it can be very useful in terms of feedback because there's real behaviors observed. A third method, one that we've used extensively, is the multi-source feedback, the 360. So we do a 360 of our residents at our pediatric emergency department, filled out by faculty, fellows, and nurses of our residents. So a typical multi-source feedback will involve 6 to 8 different observers filling out the same form. And what we focus on in the emergency department is not their clinical skills. The faculty are evaluating that. What they're focusing on is 3 questions about communication skills and 3 questions about professionalism skills around things like treating with care and compassion, being respectful to the team members, and being committed to doing the right thing, that commitment to excellence. So what we also find is the self-assessment portion is really powerful. So if we have a resident that thinks she's wonderful in every area, and yet the raters don't think she's so wonderful, there's a great opportunity for discussion about what that might mean. And we've seen real positive movement when residents realize, oh, I thought I was working hard, but everyone thinks I'm really not picking up enough patients and I'm not really committed to doing a good job, so maybe I need to up my game that way. It takes some time and effort, but once you get it up and you have a group of raters that are committed to doing it, a lot easier to keep going. Reflection, as I mentioned, with our medical students is very powerful, and we're looking at ways to incorporate this more into residency training. Again, the reflection could be real cases, could be scenarios. There are ways of actually quantifying the depth of the reflections, so they don't just turn something in, but actually do a good job of really analyzing. And as I said in this recent study that we did in OSU, first-year students, they really got better at reflection because it got covered by their coach. So they knew it was being read and they got some feedback. And I was impressed that it ended up being a very positive experience for these students. So that's it ends up being an assessment tool of their professionalism. Can they really probe these situations and discuss them in more depth? Lastly, there's this concept of a professionalism climate. So some of you may have seen the patient safety attitudes questionnaire. I know IHI has one. It's really where the individuals describe the safety behaviors in their microenvironment, in their ER, their ward, their clinic. So Penn State Professionalism Questionnaire really characterizes the professionalism climate for the individual. So in this case, for the learner. What's going on in terms of what they're observing in that environment. And we've developed one at Ohio State that's a little more behaviorally based. And in our initial studies, we had residents in the ER, residents in radiology, and residents in pediatrics define their professionalism climate. And amazing, they were different. The professionalism in those three areas was different. And we got some really interesting information about that. So this is, again, an assessment of the climate that the residents in that is going to shape those residents. So it becomes an assessment tool of not just the resident when they do their self-assessment of how they behave, but also an opportunity for program intervention. And as I mentioned, the Penn State has 36 items based on the ABIM construct. Ours was based on a safety attitudes questionnaire that focused on 7 professional behaviors and was very much behaviorally based. So, which professionalism assessment tool would you like to explore with your learners? And none is, I guess, one of the options. But I'd like you to think about the fact that whether you're a faculty member or an educational leader, that really starting to get experience with one assessment method and trying to build that into your program can really focus the learner on the fact that professionalism is that important, that it's being measured, I'm hearing about it, but also focus your efforts on making sure that the education is happening. So a couple thoughts about choosing these professionalism assessments. I think it's really useful to think about which of the paradigms are you addressing and really linking the assessment with the education. I think ideally educational programs, whether they're with students or with graduate medical education, ought to be thinking along the lines that multiple assessments are superior to one. And ideally assessments that hit multiple paradigms are going to be more powerful. So I can tell you in our residency program, we do a multi-source assessment of professionalism in the ED, and every year the residents are assessed in the ED, so we get to see how they interact in that stressful environment. We get parent feedback on their professionalism in clinic, so that's very different than the multi-source, because these are what parents think about how this resident came across. We also videotape our residents in continuity clinic. And what the faculty do is watch the videotape and judge their communication and professional behaviors, not their patient care skills. And the residents get that feedback about how professional they happened and can kind of match that up with what the parent evaluation says. So those are 3 methods that we use to look at professionalism. We also teach through a code of conduct what the professionalism values are, but we really I refuse to do a post-test on the virtues. Someday I may have to, but we've avoided that so far. So at the end of the day, professionalism assessment is a team sport. You can't rely on one person to do your assessments and think you got it. And just like different individuals confronting the elephant, if you put together all the assessments of these scientists, you come up a little closer to what an elephant really is. And I feel that way about professionalism in the assessment world. So in summary, the 3 professionalism models, the virtues, the behavior, and the professionalism identity are useful constructs for learners and for teachers. There's multiple methods to teach professionalism, and that we have to kind of recognize that having multiple methods can actually be a strength. There are lots of methods for assessment. As Wilkinson's paper points out, there's plenty of things written out in the literature. Not that there's any one best method, but there's plenty for us to choose among. And then lastly, I think there's real value in determining the climate that the learner's perceiving around professionalism. Again, for helping the learner, but also for helping us as educational leaders make sure the climate that's shaping our learners is being attended to. So what I'd like you to do is commit to action on 1 or 2 of the topics or concepts that we talked about. And by commit, what I would ask you to do in the next month is either read more on that topic, discuss with a colleague, or actually try and implement something. So in the presentation, there are references, so Sherry will be posting this online. They'll be available to you. Again, my email address is there. I'll be happy to send it to you if you want the actual slides. But if you get a chance to read more about this topic, that would make me feel so good as a teacher. Like, wow, I stimulate people to want to learn more. Wow. If you want to discuss it with a colleague, a lot of us learn through discussion. And that could be a really powerful way to be shaped by this workshop or this presentation. And then lastly, you could actually try to design something and implement it. So you get a chance on the back of your handout to jot down what you're willing to do. And again, I already told you, but I'm not collecting these. So. And we'll open things up to questions. Yes?
The last three methods you discussed, MSF and
The reflection, yes. And the reflection?
Yeah. Are they available in public domain to purchase those?
Yes, so the MSF, the multi-source, actually there's references. Wilkinson's paper in Academic Medicine 2009 has references for each one of those methods. And then this handout, the last slide, actually, this slide has references on all those topics. Yeah. So we've not published our Ohio State one yet. We're getting a little bit more preliminary data, but the Penn State Professionalism Climate has been published. Yes? In terms of profile? No, it's an interesting way to think about it because, yeah, I bet they're linked. I'll bet they're linked. And we have really not addressed, like, trying to match up our teaching method with what the learner might prefer. I think that's a sophistication that's beyond me right now. So we hit the learner with whatever we're going to use, and we go with multiple methods and hope that some of that speaks to individual learners. But I think it's a really interesting point because clearly the extroverts love the case-based discussions and reflection discussion, and the introverts, it's kind of hard to draw them out for those activities, and my guess is they probably would do better with more reflection kind of educational methods. But yeah, good point. Good point. Other questions or comments? Yes?
As you've been doing this with your residents,
Mm-hmm.
have you noticed that parent scores have been getting better?
No, I mean, parent scores have always been really good. I think we have good residents, and they really take it seriously that, when they're in our clinic, which is an underserved population, that it's really important. It's interesting, we're working on a patient-centered family home program with our internal medicine and family medicine folks, and in a 11-item measurement of the effectiveness of the resident around maintaining a patient-centered family home, we found that they didn't score each other as well as the family scored them. So I think, I think the family evaluation probably picks out the great outliers, but I don't think it gives you much fine gradation among the majority of the trainees. But it will pick out outliers for sure.
Thank you all so much for coming. Just as a reminder, our next event is our Education Day, October 17th. We have 2 separate sessions at 7 and noon, and then a reception in the evening at 5:30 with speech awards and all the other types of recognition activities and posters, demonstrations, such like. Thank you all. Have a wonderful rest of the day.